Good afternoon, ladies and gentlemen. I feel slightly tachycardic. My palms are slightly sweaty. I'm a bit short of breath. I never heard of POTS, but I know now what it means. It means Paul on the stage. Does this work? The microphone? Yeah, okay. And I am slightly nervous because this is the first time that I address an international audience on an educational topic rather than on the topic that most of you will know me from, and that's pediatric asthma. This is sort of my new career in medical education, and when doing that, I discovered that there is an entire scientific world that studies medical education. I never knew that, but it is there, and the literature there is completely unknown to the average clinical scientist. So I thought it might be fun and useful and entertaining if I just picked out one technique that I learned through studying medical education literature, because it really helped me in my clinical career, and that's the SNAPS technique. So that's what we're going to talk about in the next 25 minutes. So the scenario here is that a junior doctor, a pediatric registrar, a house officer, a specialist registrar, has seen a patient and calls the consultant for supervision. Now I'm sure that's a recognizable scenario, isn't it? And then there are two goals for the encounter between the junior doctor and the consultant. One is to provide optimal patient care to the patient, and the other is education. We want the junior doctor to learn from this encounter. And there is a way to integrate these two goals, and that is the SNAPS technique. So I've become an educationalist, and you know that you can recognize people with an interest in education because they start off with learning aims. I was glad to see that Paul did the same thing, so maybe it's in the name as well, but this is what I hope to achieve. I'm going to introduce you some of the principles of clinical reasoning that most of you will apply either automatically or consciously, and I am sure that at the end of this talk you will be able to use the SNAPS technique in your practice, either as a learner or as a clinical teacher. So basically there are three possible ways that you can get clinical supervision as a junior doctor when you've seen a patient in clinic or in A&E. The first and most common one is that you call the consultant that he says, sorry, no time, deal with it. That was at least very, very common when I was training. And I learned later through studying the medical education literature that that is in fact a very important decision that your supervisor makes for you, because he entrusts this professional activity to you. And the new hot potato in medical education science is the EPA, the Entrustable Professional Activity, which is a way of following the progress of junior doctors through their career, and it defines the level of supervision junior doctors need for a specific clinical task. Say, seeing a patient in accident and emergency, or being on call. After a while, the consultant team entrusts you with doing that task. And obviously the best way to do that is by deliberate deciding that you're ready to go, that you're fit to fly. But in my training career, this was usually done subconsciously by my supervisors. They just said, go on, and whether or not the patient dies or gets the rotten treatment is, well, it's all in the game. That was what happened a generation ago. Things have changed. Then the second thing that may happen is that your supervisor has a little bit of time, but only just a little bit. And they usually tell me, okay, tell me what you want to do. You've seen this pediatric adolescent, you've ruled out POTS, now tell me what you want to do. And that also is valid and very efficient for the supervisor, but it's not very enlightening or educational for the learner, is it? So what I would like to do is introduce you to a technique that you could use if you just have a little bit more time, say 5 minutes. Say that the junior doctor has seen a patient in accident and emergency, and that you as a supervisor, as a consultant, have 5 minutes to do the supervision. What I'm going to show you now is a video of how such an encounter usually goes. And what you will see next is Ilko. He's a third-year pediatric resident in our hospital. He's great. He's very much, he's an active learner. He's good. He's competent. The nurses like him because he collaborates well. He's the kind of junior doctor that I trust. But he's seen a patient, a real patient in the emergency ward, a 15-year-old girl sent in by her general practitioner because of acute dyspnea. That was the referral reason. Good for this audience. And what I would like you to do is put yourself in the position of a learner, even if you're my age or above. Put yourself in the position of the learner and judge this encounter from the perspective of the learner. And I would like you to grade this meeting on its educational value. So give it a score of 1 if you think this is utterly useless from an educational point of view, and give it a score of 10 if you think this is education nirvana, absolutely world class. You're going to recognize the supervisor, and once again in this first video you will see the usual approach to clinical supervision, and I want you all to score this from the perspective of the junior doctor. Is that a clear assignment? All right, there we go.
A 15-year-old girl, history of anxiety disorder, right. She's taking citalopram, also on oral contraceptives for about a year for menstrual problems.
Okay.
And she came into the ER with complaints of dyspnea, shortness of breath, for about 2 days now.
Right.
It started when she was cycling to school.
Okay.
She doesn't report any wheezing nor any chest pains. She does have the sensation that her breath is like holding somewhere in her throat.
Okay. And any tingling around the mouth, or?
She did describe any tingling around the mouth. Yes,
right.
yes.
But no excessive yawning or dizziness or?
No dizziness.
No.
Did not specifically check yawning.
Okay.
Didn't see her yawn.
Right.
I didn't specifically ask.
Okay.
No.
And the onset was not like on and off, just
it was not
immediate.
It was not that immediate, not acute.
Right.
No.
Okay.
It started during cycling to school when she started feeling this dyspnea, which hasn't gone away since.
Okay. Is she a smoker?
She's a non-smoker.
Okay. And the family?
It's negative for pulmonary conditions, asthma, also for embolism.
Okay. And the physical?
Physical was normal. She's not objectively dyspnoic. When I look at her, I do not see her being short of breath.
Right.
Normal respiratory rate, 20 per minute. Pulse is a bit elevated, 120 per minute.
Okay.
Without a fever. Normal O2 sats.
And BP?
BP is normal, 113 over diastolic 70.
All right.
Adequate for this age.
Okay.
So normal BP and also a normal cardiac and pulmonary auscultation.
Okay.
Normal breath sounds.
Right.
No wheezing, no crackles.
No edema.
No peripheral
No
edema.
swollen legs.
No swollen legs.
Right.
No, I didn't measure it.
Okay.
Objectified me by measuring the lower leg, but not eyeballing it. No.
No, and it's not red and tender either.
It's not. No.
Okay.
No.
So what's your working hypothesis?
That would be hyperventilation.
Right. And your plan?
There is, I guess, a differential diagnosis of pulmonary embolism,
Okay.
given her use of oral contraceptives
Yeah.
as well. It's a small chance, but you shouldn't miss that diagnosis.
Okay.
It's not asthma.
So basically you're suggesting rule out PE and then send her off to physical therapy.
Physical therapy. Rule out PE by checking her D-dimers.
Right.
If they're low,
Yeah.
refer her to a physical therapist.
Yeah. I would agree. Go ahead and arrange it and we'll see.
Thanks.
Okay? You're welcome. Okay. He's far more patient than I am. Right? Okay, so on a scale from 1 to 10, how educationally valuable is this encounter for Ilko? John, what do you say? What's your score for the?
It's rather low.
Yeah, give it a number.
A 2 or a 3.
A 2 or a 3. Okay. Anyone with a higher score for this? 4 to 5 higher. Sorry. Any higher? 4 or 5 is the highest. Okay. John, why 2? What did I do wrong?
Well, he didn't learn anything. He didn't learn anything about. There was no comment, constructive comment about what he'd done. There was no real communication other than grunts. He didn't have. It was a pretty narrow
differential
diagnosis that he was given, and he was just sent away, go away and do it.
Is this recognizable in any way? Is this how it usually goes?
Unfortunately.
Yeah. Okay. So far so good. I was hoping for that. The people who gave the 5, there must have been some things that I did right here. Please, what was it?
You listened to him a little bit. You asked him about the edema and the healing of the limbs, and so there was some interaction.
Okay.
So
Yeah.
He answered that you were a patient, but at least there was some interaction.
Yeah, I did ask some questions, absolutely. Yeah. But you're saying, John, those questions didn't help him much, did it?
I don't think
No.
anything.
Okay. And why is that? Why is this not very educational, this encounter? I think that has to do with the reason this supervisor, let's call him Paul, asks the questions. So, and who of you has an idea that the kind of questions I ask, what is the reason to ask those questions? What am I doing at that time?
You use a lot of closed questions. You put him on the defensive because you could tell from his body posture he went defensive. You might have sort of gone along with, well, had you considered other physical findings? Anything else you'd like to tell me? Sort of quite open.
Right.
Which
Okay.
Did he have red? Did he have this? Did he have that?
But apparently that is quite a common approach, that supervisors do this. And basically what I'm getting at is that what they do is that they are clinically reasoning themselves at that very moment. But it's rather implicit, it's not out in the open. So this is a scheme of how experienced physicians approach diagnosis. And I'm sure you all recognize it, that at the moment a patient enters your office, you start acquiring the data by the history, and immediately that will lead to hypotheses being generated in your head. You can't help it. That's how we work and think. And we go from data acquisition to that hypothesis by making it a recognizable, graspable clinical problem that we've dealt with before. And we've dealt with it before because we have a lot of knowledge, and we've seen a lot of patients with various presentations, and we can put that into context. And that is difficult for junior doctors because they lack the experience, they lack usually also the context information. The knowledge is there, but they don't have this automated use of the knowledge that we have developed based on experience and context. So what I was doing really is generating in my head a hypothesis what this might be, dysfunctional breathing, hyperventilation, and that I was sort of, I needed a bit of additional information to fine-tune the problem representation and test the hypothesis. And that's why I asked, is there any dizziness, is there excessive yawning, because those are symptoms of hyperventilation, as you all know. But as long as that process remains subconscious, it's very hard to follow for the junior doctor and hence hard to learn from it. So what I'm going to do now is show you a way in which you can make this clinical reasoning process more explicit and therefore teachable. So this is the same resident, the same patient, the same supervisor, but deliberately applying a technique, which is the SNAPS technique. And what I would like you to do once again is to score the educational value of the meeting and try and identify what I do differently from the first time. All right? Here we go.
15-year-old girl.
Yep.
With shortness of breath.
Right.
She has a history of an anxiety disorder.
Mm-hmm.
She's taking citalopram for it, and she has been on oral contraceptives for about a year for
Mhm.
menstrual problems. And she's complaining of shortness of breath, dyspnea mainly upon exertion for about 2 days. It started 2 days ago when she was cycling to school. It hasn't gone away since.
Okay.
I asked if she had any chest pain. She didn't have chest pain. No wheezing. She does have a sensation of some tingling
All right.
around the mouth.
Mm-hmm.
And when I looked at her on physical examination, she had a normal respiratory frequency, about 20 per minute, with normal O2 sats, normal work of breathing, normal blood pressure, normal temperature, a bit of tachycardia though, about 120 per minute her
Okay.
heart rate, with a normal cardiac auscultation and also normal breath sounds,
Okay.
without any wheeze or any crackles.
Okay. Can you summarize the case in one sentence, please?
Yes, that will be a 15-year-old girl with a history of anxiety disorder, with shortness of breath on exertion for 2 days, with tingling and a normal physical examination.
Apart from the
Apart from
tachycardia.
tachycardia.
All right.
Yeah.
What do you think is the most likely diagnosis?
I think that would be hyperventilation.
Okay.
Yeah.
And what argues in favor of that?
Her age,
Mm-hmm.
I would say, and her gender,
Mm-hmm.
more common among girls.
Mm-hmm.
So the epidemiology
Okay.
would argue in favor
Sure.
of it. Yeah, and her history of an anxiety disorder.
So a comorbidity, basically.
Yes.
Yes. Okay.
This does make her a priori chance a bit higher.
Okay. So you're saying the epidemiology and the comorbidity argues in favor for hyperventilation?
That's what I'm saying. Yes.
Okay. So what have you considered otherwise?
I did consider asthma,
Right.
but I think we can exclude that because she doesn't have a history of asthma or wheeze,
Okay.
and there is no current wheeze.
Wheezing and no increased work of
And no
breathing.
increased work of breathing.
Right.
Yeah.
Okay. Anything else?
Yeah, I did consider PE, pulmonary embolism,
Okay.
also. And I think we should rule that out, basically.
Why?
Because, well, she is a 15-year-old girl
Mhm.
on oral contraceptives.
Yes. And that increases her risk
Yes.
from very low to low? Or?
To yeah, a bit less low probability.
Mhm.
Yeah, so
Okay.
it's still a much lower probability than hyperventilation.
Sure.
We shouldn't miss that diagnosis.
Because it has major consequences.
Yes.
Okay.
Yeah.
Okay. Is there anything you would like to ask me about your differential that could help you in your further steps?
I'm not really sure what the a priori chance with the probability of pulmonary embolism in this category of patients.
Yeah.
That is low, but
Teenagers on OAC have a prior probability of about 3 in 10,000 of having a pulmonary embolism.
3 in 10,000.
Yes.
Very low.
It
actually.
is,
Yeah.
yes. But they do occur, even rare diseases do occur.
I see.
And you're saying that I do not want to take the chance of missing this one, right?
That's what I was saying.
Okay.
Yes.
So what's your plan, your proposal?
I think we should check her D-dimers
Sure.
to rule out PE then.
Okay.
Yeah.
So I agree, and my suggestion would be, while you wait for the result of the D-dimer, have a look at the guideline bank and see if you can find whether these values are applicable in this age group as well. Whether you can find any data on the likelihood ratio of D-dimer testing in this particular age group. That would be extremely helpful if you could present that to handover tomorrow, because this is a diagnostic dilemma that we have occasionally.
I see.
Do you have time to
I think
have a look at the literature and prepare a very short presentation for tomorrow
Yeah.
morning?
Maybe while I wait for the D-dimers, I think I will have
Okay.
time. Yes.
Okay, apart from that last assignment,
It's a 1.
what's your score on the educational value of this meeting? That's all worse than the previous one. That's okay. John,
Well, up until that last time,
I
I was
know.
going to give you a 10.
I couldn't help myself. Thank you. Right, I asked you, what did I do differently? Please yell. What? Yes?
The structure was very interactive. I think it was very good that you asked them to summarise.
Okay, so that was the first specific thing that I did differently. I asked him to summarize the case in 1 or 2 sentences. Yeah. Usually when you ask a house officer to do that, they start repeating everything. That's something else than summarizing, right? And it takes time and effort to summarize well, and he did very well, I think. Okay, anything else?
You let him talk for longer.
Yeah. I didn't interrupt him while he was telling this, while he was doing the narrative. You're right.
But there was lots of active listening.
Okay. In what part of the?
Well, just while you were listening to him, there was good eye contact, the kind of
More empathic humming.
There were more positive grunts.
Thank you. Positive grunts. Okay.
You always smile.
Well, I didn't script that actually, but there were a number of very specific questions that I asked him after I asked him about the summary.
You asked him what he wanted to know from you.
Yeah, that was agreed, and that's part of the technique, but it's towards the end, and there's something between the summary and the what do you want to know from me.
When you put forward the diagnosis, you asked him why did he think that was
Exactly. So I didn't only ask him what his working diagnosis was, but also what are the clinical features that support that. And there was one other thing.
What else did you?
Very good. Now, you guys have recognized the basics of the SNAPS technique. And coming back to that scheme of clinical reasoning that I showed you, what this tries to do is to make explicit both the problem representation and the illness scripts that belong to that. And the problem representation is the brief summary. So I have a good resident, a good registrar will make that accurately, and a young and inexperienced house officer will need your help to fine-tune it from a repetition of everything that he's gathered to the core of the problem. And illness scripts is basically what clinical scenario fits best with this problem representation. And the easy way to do it is to ask 3 what questions, which you all recognize. What do you think is the most likely diagnosis? What supports this? And what else have you considered? And with an experienced registrar or under time constraints, that could be either what is most common and what are the elephants in the room, the ones that you really don't want to miss because they have serious consequences, of which pulmonary embolism obviously is one. Okay? And I do agree that the differential could be much longer, but this is a working differential that you could absolutely work with in accident and emergency. Is this principle clear? Right, okay, so where's the SNAPS acronym? Well, here it is. So basically you ask the learner to summarize the case briefly and then narrow and analyze the differential diagnosis by these 3 what questions. And then you allow the learner to probe the teacher by asking questions about uncertainties, difficulties, or alternative approaches. And that was a bit on the run here in this encounter, but it is at least more useful and fun than the original way that the teacher is grilling the learner about his knowledge. All right? And then obviously there needs to be a management plan, and then you saw me at the end do the last S, select a case-related issue for self-directed learning, which feels like a burden, but it has an educational background in that repetition, especially repetition, look up of knowledge specifically based on a patient that you have seen, will help you memorize this clinical scenario. So there is a usefulness to it, although it always feels a bit, what's the word? Nasty, maybe. Anyway, it puts Paul on the stand, right? But on the spot. But this is the principle of SNAPS. And this is easy to memorize, I think, and easy to apply. And there has been a bit of research, and once again, this is an area of research that we usually don't see. For example, in this study from the United States, they compared doing the SNAPS approach in the supervision of medical students having their first clinical rotation. And then they audio taped the supervision sessions and had them scored by independent observers. And basically what they found was that it's a very complicated slide, but what you can basically see is that using the SNAPS technique, the learners provided more differential diagnoses and asked more questions. So they were more actively engaged, and that's exactly what you hope to achieve when you supervise a learner. So I have come to the experience and the conclusion that this is more engaging, more fun, and more useful both for the learner and the clinical teacher. And it allows me as the supervisor to better gauge the level of clinical reasoning that my pupil has arrived at. This reinforces my view of Ilko as a competent third-year resident that is growing normally in his career. And there is some evidence, and I don't have the time to show it to you in detail, that this does appear to promote clinical reasoning in learners. So I would like to leave you with this. It is an easy technique, and I'll skip this one and this one as well. From the point of view that junior doctors do deserve a supervisor who not only takes a bit of time, but also a bit of educational effort in making such an encounter useful. And once again, I've come to the conclusion that this is not only more effective and efficient, but also much more fun. And I do hope that you will take this home with you and try it out if you haven't done before. Thank you very much.